welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Pho, founder and editor of KevinMD. Rate and review the show at kevinmd.com/rate. Subscribe at kevinmd.com/follow. Today on the show, we have Karla Lester. She's a pediatrician, and her latest KevinMD article is titled, What It Takes to Build a Pediatric Weight Management Program. Karla, welcome back to the show.
Thank you for having me. Thanks again for your awesome platform, Dr. Pho.
So you've been on the show many times, and for those interested in hearing more about Karla and her story, just go to kevinmd.com/podcast and search for Karla Lester. But I want to go straight into your article titled, What It Takes to Build a Pediatric Weight Management Program. So tell my audience, walk my audience through it and share the story of why you decided to write it.
Okay, thank you for the opportunity to share because it's really timely. So I've been working on the childhood obesity epidemic for almost 20 years of my career. And one of the things I did was I started a nonprofit called Teach a Kid to Fish in 2007, and I left my practice. And I was really firm that I would not start a weight management program, that it wouldn't be clinical, that it would be focused on public health, community building, and policy and advocacy specifically. And so what I did was I took, our organization's American Academy of Pediatrics puts out these amazing expert committee recommendations and policy statements. So in 2007, the expert committee recommendations came out for how community pediatricians should prevent, assess, and treat childhood obesity. Yep. And so I use that framework to launch my nonprofit, but the treatment arm has a staged approach to treatment recommended. So I had, from scratch, from my own funding and writing grants, created these programs in the community. And so I first started with stage one was working in primary care. So I worked with DHHS out of the CDC grant, and we developed Foster Healthy Weight in Youth, Nebraska's clinical childhood obesity model, got that out to pediatricians, family docs across the state, and did amazing work there. So I'm like, okay, great. Next up, okay, we needed a multidisciplinary approach, which is stage 2 to 3. So I created that, worked in the community, did BodyWorks programming, which was an amazing program that my nonprofit, we got the funding, we ran it in 20 different sites across the community. Then famous last words, I'm not going to start a clinic. Well, I get all these calls from school nurses and pediatricians. What I'm going to do with this kid? This kid can't even walk down 2 steps without turning blue when he's in first grade. I literally feel like he's going to have a hypertensive crisis at school. What do we do? And I'm like, well, obviously I'm the pediatrician who's taken this on as my mission. So here we go, And so what I did was I started to look at what was out there, looked at different models, obviously, looked at the one at Children's in Omaha. My board really wanted a community program where all the hospital systems were contributing, which I found out after trying that for 3 years and trying to get everyone around the table is a complete joke. And I don't want anybody to not have a feasibility meter or realistic meter that's probably not going to happen in any community. But anyway, so I got a grant to work with a healthcare finance consultant. She was amazing. She was recommended by other physicians. And so she and I started looking at like a 5-year pro forma for what it would take because these clinics are not typically money making. And so then I started working with, strategic partnerships, started working with the evidence base of all the components that we need, how many hours of touch points, contact hours they need. And it took me literally 3 straight years of working these partnerships and grants and working with children's to finally launch it. And then I was the pediatrician in January 2015. Well, all the political stuff happened. It was pretty grueling. I incurred a lot of moral injury through that process. And now I'm on the American Academy of Pediatrics section on obesity listserv. And I see this listserv come out like the last couple of weeks. Anybody have any resources for launching a, medical component of a weight management clinic? I'm getting asked by my, C-suite for the medical side of the adolescent bariatric surgery program. And I'm just like flooded with almost like trauma. Yeah. And I'm like, here I am. I started that journey specifically for the clinic 10 years ago. And there were some amazing things that happened, but I think reflecting on it, I want to help people avoid these pitfalls, and I can see they're already, falling for them and starting to jump through the C-suite hoops, and they're chasing their carrots and handing that power and that, even maybe their vision over to these folks. So I was like, I need to write about this, and I need to talk about like what it takes and share my journey. And I can't help everyone avoid, all the pitfalls, but to be mindful of, what it takes and what you need as a visionary physician to manifest your vision, and to be able to, stay the course, but also be willing to let it go if you
Sure.
need to.
So let's talk about that scenario, that physician that you brought up from that listserv. Someone from the C-suite said, we should have a pediatric weight management program, make it happen. So now you talk about your journey. You mentioned things like pitfalls, moral injury, a lot of things to look out for that physicians aren't necessarily trained for. So put yourself in the shoes of that physician who was just asked by the C-suite. What are some things, red flags, that they should look out for?
I think the number one thing is if you have an executive coming to you, an administrator who's coming to you as a physician, asking you to provide like the pro forma. I mean, it was one thing for me to create that. I loved doing that with the healthcare, but I was on my own with my nonprofit, so I wasn't underneath anybody asking. But that's what these folks operationally, they should have the operational infrastructure and the expertise to run those numbers in their sleep. I mean, to launch these clinics. And so I think that, it's that kind of proving that I don't like. It's like they're putting that burden of proof, and it just creates that power divide that I was really, a victim to. First of all, I would say, what is the vision? I would ask the administrator, okay, well, what's your vision? That sounds exciting. I'm so, be excited, because maybe they are a visionary. Maybe they want really good things to happen. I mean, in reality, they want more adolescent bariatric surgeries, and they want more funnel to their contribution margin, because it really, like, more special studies, more procedures, more referrals to specialists. And then the other thing that people don't want to talk about, they don't want to talk about contribution margin, but they don't want to talk about that you have to show to insurance companies 6 months of failed medical intervention and a commitment by the patient and the family in order for an adolescent, I don't know what it is for adults, to qualify for bariatric surgery to even be considered. And so, I think it's a little bit, I don't know, suspicious that, medical, I was told that, like we only created this clinic, Karla. I mean, I was told by a surgeon, because we want more bariatric surgery.
Sure.
Offer bariatric surgery on the first visit, so I think, what's the shared vision, and, just to have red flags up, to like maybe lack of operational infrastructure to support it if they're asking the physician to provide and work on present the financials to them.
So one of the things that you had mentioned was politics. So tell me how that factored into that path where you tried to start that clinic.
So I had been with my nonprofit, it was just an exercise in community politics and working with funders and, these power plays, and anyway, chasing carrots, jumping through hoops. And I did a lot of that. I mean, you're going to have to do that. So the community politics around trying to pull the healthcare systems and the up and downs of that, we have two healthcare systems in Lincoln. We have CHI, and we have Bryan Health, and they're great health systems. They had supported another physician's nonprofit, both of those organizations, especially CHI, he had duplicated my mission, actually. So, I mean, it was really hard. I had meetings with them that were promising, and then they never, they just never supported. In fact, one time I had pitched a really amazing collaboration with their community benefit department, their foundation, and was asking for like sustainable funding, or 3 to 5 years of funding for my nonprofit. And here's your give, here's your get, the strategic partnership, to the tune of about $100,000 of support per year. And which is not bad for a community hospital and what we were doing. I never heard anything. And then I reached out to the head of their foundation and I said, any words, any feedback? I had a great meeting with the head of their hospital. And he said, it's been a really tough decision, but we want to know that we're really committed to your, mission, Karla, and we're going to give you a check for $750. I mean, that's literally the level of support. And so I was like, keep the check. And this person was not involved actually in those meetings. And he was just wholly embarrassed at that, But anyway, that's kind of the level literally of politics. You have to write 10 grants to get one in the community. But anyway, so none of them wanted children's involved in the community. So that was kind of not going to happen, where the health systems would all work together, which worked out well for me because I was able to work with children. So they expanded their clinic to Lincoln. So I was able to identify the need and then the politics of putting all the pieces together, because there's so many pieces that go into a clinic like that, because you need at least like 26 to 75 hours within a 6 to 12 month period to show significant reduction in BMI and comorbidities in children and adolescents of comprehensive behavioral intervention. And that's all the, goal tracking and monitoring and education and, expertise and behavioral support and family-based intervention. And so how do you do that? You can't get it in the clinic when they're coming every, 2 to 3 months. So I created a whole energy fitness program and worked with the university with a psychology department, specifically a child health researcher, Dr. Tim Nelson, amazing, who has NIH grants and everything. And we created a whole database and whole energy fitness program, looked at all these measures, not just BMI and weight. And then once children said, their CEOs who I had been working with, and they realized this was their lane. They don't want to supplant. They can be additive and fill gaps, which I agree with. And it's a really amazing marketing opportunity and partnering opportunity that they don't have and that I had and I brought to the table, and a lot of vision I brought. Once they realized that, then their COO stepped up, and I had presented with my healthcare finance consultant. We presented to children's leadership team a proposal to support the expansion of their Heroes program to the Lincoln community in its entirety. And then I heard nothing. Then they call back and say, oh, we're going to support it. Karla, I hope you're excited. So of course I'm thrilled. I'm 3 years of grueling hell. And then I put down the phone and I actually was crying. Of course they want me to be the pediatrician for it. And then crickets after that. And then the more the politics and more of the hoop jumping. And it's oh, you're going to have to be an independent contractor. We're not going to have you an employed physician. Oh, you're going to have to cover your own malpractice. Oh, by the way, you're going to have to support the entirety. Your small nonprofit is going to have to support the entirety of all the community programs. So more grant writing to the tune of, I supported $100,000 in cash from grants from the AAP Community Health Endowment, a community foundation, other donors, to get all of this going. And I just kept saying, oh my gosh, the pressure. Anyway, I think that, obviously I had an extraordinary case, but those are some of the pitfalls. If you recognize those early, that you're going to have to do a lot of the hoop jumping, and there's this power divide, and they're not respecting your time, your expertise, and they don't have a shared vision, and especially a shared vision to sustain, these executives, these administrators have to back up the clinic, because that didn't happen.
So who did you have to turn to for advice? Because a lot of these skills of running a nonprofit isn't necessarily innate to physicians. Who did you turn to for advice?
Well, I had an awesome board of directors. And I worked really closely with my health department. Actually, my strongest mentor and closest mentor was her name, Charlotte Burke. She's actually an RD, but she was head of health promotion and outreach at our health department. And she's just an incredible thinker. And she's my go-to person. But I had an awesome board and I listened. And I knew nothing about starting a nonprofit. I learned along the way. I remember leaving my practice and then my first day of teaching it to fish, where I just had I had an office from Lancaster County Medical Society, and I had my husband and I invested $15,000 and I wasn't getting paid and I had no staff, but I had a good board. And I just remember thinking, WTF myself into it's me at Google. So I would meet with somebody in the community. They say, meet with these 10 people. Then I meet with those 10 people, each of them, and say, meet with these 10 people. And I just listen. I'm a good listener. And I just listen. And I built so much trust up. And I developed a strategic plan with the entire community. And I really highlighted and elevated people's work and amplified it. But the thing I think that I learned the best is manifesting your vision through community partnerships and a shared vision and working with those kind of key stakeholders.
We're talking to Karla Lester. She's a pediatrician. Her latest KevinMD article is titled, "What It Takes to Build a Pediatric Weight Management Program." Karla, if you were to do this journey all over again, is there anything that you would do differently?
Yeah, I'd be willing to walk away. I mean, I think you got to have an out. If you're a physician, the other thing is I would probably not have worked with health systems in it. I would have thought of it in a completely different way. I would have changed things up. I wouldn't have felt like that was my only chance, I wouldn't have jumped through the hoops. I mean, someone would have, but I think I would have spoken up for myself. I would have, my attorney said, when I finally got it going and we had a launch date, and I said, they're not even giving me a contract and they're not even providing a template for a contract. And they said, I have to cover my malpractice insurance. And he said, hey, Karla, do you realize that you don't have to do this? You don't have to do this. You don't have to be the pediatrician for the clinic. Maybe your role was to get all of this going. And I was like, no, I need to do it because this is what I want to do. Nobody else could do it. I mean, it's true. But even with that, I would have been willing to just go back and negotiate and say, listen, you're going to need to cover the costs of this community programming. And if you don't share that vision, then this deal is off. And I would have walked away. And I think that's the number one thing. And also just being really aware of what I call the operational red flags, is that if they're depending on you as a physician, again, to create those pro formas, to not be partner with you, and they're not coming to you with the vision, no, I wouldn't do it.
My final question, what are some of your take-home messages that you want to leave with the KevinMD audience?
Well, I want to say, there's so many ways that you can manifest your vision, and you don't have to depend on anyone else to, in the end, manifest your vision. And I understand, we're all stuck in these kind of paradigms of how we think things have to work. And, sometimes that is true. I mean, if you want to get paid, you need to work with healthcare systems, but, be willing to just really be open, and also to protect yourself, and first, to really don't get so involved in over functioning and fixing and solving things. You can show up and tend to the causes in your life, but you're not there to fix and solve. And, really, when we lose track, like I did, of your internal capacity to be able to say, I need to go, I need to leave, that's a huge red flag. And so I think, just be willing to walk away.
Thank you so much again for coming back on the show, sharing your story, time, and insight.
Thank you.